everyone. Welcome to the Geriatric Healthcare Lecture Series sponsored by the Northwest Geriatrics Workforce Enhancement Center. My name is Barbara Cochran and I'm the Associate Director for the Northwest GWEC. And I just do want to remind you again, if you, oops, I need to move this up here. If you haven't yet filled out a profile form for this series, please do so. Your site coordinator will have that. Your site coordinator should also have provided you with a handout as well as an evaluation form. Please fill that out also. And if you are interested in viewing this presentation again or letting others know about it, it will be posted on our center's website within about 48 hours. That website address is nwgwec.org, and it's posted under the Geriatric Healthcare Series. And today I'm very happy to introduce to you Dr. Thuan Ong. Dr. Ong practices primary care and consultative geriatrics in inpatient and outpatient settings. He focuses on promoting a healthy lifestyle among older adults and is an assistant professor at UW's Division of Gerontology and Geriatric Medicine. There he educates other health professionals to be competent in the care of older adults. He received his medical degree from St. Louis University. He completed internal medicine residency at UC Davis and completed geriatric medicine fellowship at UW. He is a geriatric academic career awardee of the US HRSA, which is the same funding agency, Health Resources and Services Administration, which sponsors the Northwest GWEC. And he's also medical director for Providence Hospice of Seattle. Today he's going to talk with us about hypertension in older adults, and welcome, Thuan.
Great, thank you very much, Barbara. Good afternoon, everyone. We're going to be talking about something pretty mundane, such as hypertension in older adults. So just a little bit of background before we proceed. It's something that's observed in older adults. As we get older, the arteries of older adults begin to harden and they become much more stiff. And that's related just to the normal process of aging and calcium deposits that happen over a period of time of just simply living. And so it's observed that 2/3 of people over the age of 60 years of age and older are likely to be hypertensive. And it's related to these hardening of the arteries and stiffness of the arteries. And so as you see in preceding slides, the prevalence of hypertension increases with age. And it's so common that some researchers have thought about, well, as a person gets older, does that older person need a higher systolic blood pressure to be able to perfuse organs and to perfuse brain? And so the question is this correct? And so this is all within the background of new data too, that many of you might have heard. It actually appeared in the New York Times and within the lay press as well, where it talks about lower blood pressure. The results of controlling lower blood pressure could be quote unquote life-saving. And so this is the SPRINT trial that we'll talk about in a bit too. And then within this diagram as well as this talk, we'll talk about how to interpret these new results and how to put this into clinical action. And we'll talk about a plan on how to manage it in our very older adults as well. And so I've said that this is something that is pretty mundane, but in actuality, it's pretty complex. To this very day, there's still controversy about how to best diagnose hypertension and how best to treat it. And so this is even extrapolated even to older adults. And so there's more and more controversy even in older adults, where the editor of the British Medical Journal back in 2012 said there's a lot of controversy about it in older adults. So hopefully by the end of this presentation, we'll talk about what are the goals of antihypertensive therapy. We'll recall some of the evidence for current blood pressure targets in older adults. We'll discuss some points for aggressive and lenient blood pressure control in older adults. And I'll try to outline a practical approach in managing hypertension, particularly in older adults. So I'm going to start off with a case presentation, and this is a gentleman that I actually cared for within my senior care clinic at Harborview Medical Center. So MK is an independent community dwelling older adult. He's 82 years old, and he's coming into clinic just for management of heart failure. He's completely independent with his ADLs and IADLs. He walks daily, approximately half a mile daily, and takes to public transportation without any problems at all. He has a remote smoking history, 23 pack years. He drinks alcohol still, 3 drinks a day. There's no illicit drug use. He's intermittently positional lightheadedness with documented periods of orthostatic hypotension. And so he talks about on occasion when he stands or he changes his position from his supine position to standing, he feels a little lightheaded, but it's a very fleeting symptom that he has. And we've been able to document some periods of orthostatic hypotension in clinic as well. But fortunately, he's never had any falls. His past medical history is consistent with coronary artery disease. He had a myocardial infarction before where he had a stent that was placed. He has adult onset of diabetes, but decently well controlled. But due to the fact that he's had it for so long, he suffers from neuropathy and retinopathy and also kidney damage from that. And so that causes chronic kidney disease stage 4. He has high blood pressure, of course, and he has diastolic heart failure as well. So here's a list of his medications. He's on 2 different types of blood thinners. He's on a beta blocker. He's on an ARB to control his blood pressure. He's on a diuretic. He's on a calcium channel blocker. He's on a nitrate to control some of his angina. He's on a cholesterol pill and also insulin and vitamin D and calcium. His examination is listed there, and so it's noted that his BMI, he's overweight. He's not orthostatic at this clinic visit, but other than that, it's pretty unremarkable except for the peripheral edema that he has. And this is his blood pressure. And so this is over a period of time from February to July in 2012 when I was seeing him. And so you see that there's elevations and deviations from that normal outline there, where that red line indicates where you should be able to fall in where it's normal. Below that line, it's too low. Above that line, it's too high. And you see that he has these blood pressures that's been documented within our clinic that bounce around quite a lot. And so I think that for many of you who practice in the clinical arena, you will notice this and see this and recognize this as very common. We'll come back to Mr. MK later. So some clinical questions that naturally should we all think about is what should be the goal blood pressure be for someone like Mr. MK? And what's the goal of antihypertensive therapy to begin with, actually? So before we start that, let's talk about some of the basic definitions of what hypertension means. And so what Table 1 illustrates here is basically the definitions of hypertension and how it's evolved over time. And so believe it or not, during the 1950s and the 1960s, a blood pressure of systolic blood pressure of 180 was actually considered kind of normal. So anything below 180 was, well, that's okay. That's not so bad. But as the decades progressed on, you could see that to the present time, it's to the 140s. Anything that's lower than 140 would be normal. So much so that now that in Table 2, it illustrates in 2003, this is what the JNC, the Joint National Commission Committee, stated that this is how you would define as normal blood pressure. So you can see the differences in the years from what it was in 1950 to 2003, where normal is considered anything that is less than 120 in terms of systolic blood pressure. But back in the 1950s, anything below 180 was considered pretty normal. And part of this reasoning is actually related to the fact that there's been great advances in the treatment of hypertension. So going back to this slide, the reason why we define a state of being as a disease is we balance out what the adverse risk of the treatment is versus what the benefits of the treatment is. And back then in the 1940s and the 50s, we had horrible treatment for high blood pressure, where it was incredibly unattainable, where the side effects were intolerable. And so at that point, well, we would tolerate higher blood pressures because the treatments weren't that great. But as advances in medicine progress, we could see that more and more better received and accepted blood pressure treatments, actually, that's why we have lower guidelines now in terms of hypertension. So just coming back to the Joint National Committee, JNC7, was, this is what's defined as normal. A systolic blood pressure that's less than 120 and a diastolic pressure than less than 80. For the most part during this talk, I'm going to focus mostly on the systolic blood pressure. And that's what most individuals with older adults will focus in on, is really the systolic blood pressure. And then there's also other states too that is defined by JNC7 as pre-hypertensive, 129 to 139, and stage 1 hypertension and stage 2 hypertension as well, that is outlined on your slide there. And this was back in 2003 that the JNC7 came out. In 2017, there's new guidelines out now from the Association of the ACC, American College of Cardiologists. There's so many abbreviations, I kind of forget about what they all stand for. But the ACC recently came out with their own blood pressure clinical practice guideline. And you'll notice that normal is still exactly what it is in the JNC7, but now they have a new category that is called elevated blood pressure. It's not pre-hypertension anymore. It's elevated blood pressure, and it's from 120 to 129. And that is actually a significant range versus the pre-hypertension. It went from 129 to 139. And so you see, as we progress throughout the years, as our treatments for blood pressure get better and better tolerated, that it gets more narrow and narrow. And so that's also translated now into stage 1 hypertension and stage 2 hypertension, as well as those also move down frame as well. Back in 2003, stage 1 was 140 to 159. Now stage 1 is really 130 to 139. And so you see the differences now. Now that we've defined hypertension, let's talk about what it means to be old. And so you'll see that many people will have different definitions, and the definitions of being old is incredibly variable. And part of that is that we're dealing with a heterogeneous population. That's why I actually went into geriatrics, is that there's not a single algorithm to be able to treat an 85-year-old. I'm guaranteed that I'm not going to see the same 85-year-old in my clinic that walks through that door. Every single person that walks in is an individual. And so aging is a very continuous process. But in our culture, we pick an arbitrary number to define what old is. And oftentimes, it talks about people over the age of 65. 65 and older is arbitrarily in our culture defined as old. And that just so happens that that's when Medicare actually happens. And so when you're able to enroll into Medicare, that's when it's defined as old. But that switch just doesn't automatically turn on when you turn to 65 and you become old. So thinking about aging as more of a continuous process that we'll talk about in a little bit too. But there are researchers that would define young old as people from 65 to 74. There's older old from 75 and 84, and there's the oldest old that are 85 and above. And so these are some terms that you will find within the literature into defining what old really means. And we all use age as a surrogate for how frail a person is. And so you, within your own clinical practice and your own personal experiences, probably have come across people who are 85 and they're quite robust, and come across people who are 65 or even younger, and they're probably not that robust as that 85-year-old. So just thinking about aging as a more continuous process. There's two people that I highlight down here. Mr. Singh is 106 years old, and for those of you who don't know him, he is a gentleman from India that he was at the age of 92, did a marathon in 5 hours and 40 minutes. And at the age of 100, he did a marathon in 8 hours. And so just to give you an idea of how heterogeneous aging is, really. And Betty White, of course, 96. For many of you who watch TV, she's always still on commercials, so, and very active and engaged still, right? So when we talked about what old meant, these are other guidelines out there that are stratified based on purely on age. And you'll see JNC7 and JNC8. These are American institutions, the Joint National Committee. And so you see that they'll pick these ages arbitrarily, 60 and above, for example. AHA and the ACC, American College of Cardiologists, also an American institution, picked also the age of 65 as well. But then when you go lower down this table, these are European colleagues that also have guidelines on what the goal blood pressure should be for people who are older. And you'll see that they actually use the 80 years old. And so they go up to a much higher range as well. So just so that you see that there's a difference in terms of practice clinical guidelines out there, depending on what country you practice in, if you're in Europe versus the States here as well. So the take-home point with this slide is that there are differences in practice guidelines and that aging is truly a continuous process. So what are our goals of our therapy? And so American Heart Association, like our previous slide indicated, recommends that your goal blood pressure should be less than 130 over 80. The reason why we want to get our blood pressures lower is that we're trying to decrease the mortality and the morbidity that is associated with high blood pressure. And so we're trying to decrease the cardiovascular risk and the renal effects of long-standing hypertension on the body, right? And so there's a continuous association that exists with higher blood pressures with an increased risk of coronary vascular disease, cardiac vascular disease. As a geriatrician, though, what my goal is not only trying to limit that morbidity and mortality, but what I'm trying to preserve is to expand the disability-free survival. And so what you have here, I'm going to try to pick this up, is that on the x-axis you have time, and it's over age, and then on the y-axis you have the percent survival here, right here. And so this graph illustrates that these are people who are alive, the percentage of people who are alive at that age that are not disabled. And what I'm trying to do as a geriatrician is I'm trying to move this curve over here to that dotted line. That's what the goal of my hypertension therapy as a geriatrician. I'm trying to shift that curve over to make people live longer where they're not disabled from their cardiovascular disease. Okay. And so why is that important? Well, that's important because hypertension causes severe disability. And so this is a population-based data and research that they looked at. So they followed individuals in Boston and the New Haven area for a 7-year period, and they looked at, well, what kind of diseases cause significant disability? And so you have over here, on the subset number 1 is what is called catastrophic disability. And catastrophic disability, what that meant is that something happened that caused these individuals to have an impairment in 3 out of the 6 ADLs, where the previous 1 to 2 years, they had no impairment at all. And so these are the conditions that caused that to happen. And so strokes, hip fracture, congestive heart failure, pneumonia, and coronary heart disease. And so you see that what I highlight here are the cardiovascular disease that hypertension has a role in. And so having a stroke, having coronary heart disease, and congestive heart failure, hypertension actually has a role in causing the disability. What you have on the x-axis is its impact upon males and females. So the conditions that are on the right to the 0, and let me move this. So the conditions that are on to the right of the 0 affect men more so than women, and the conditions that are on the left to the 0 affect more women than men. And so you could also see that the exact same thing happens in the subset number 2, where there's progressive disability. And so this is very similar to the catastrophic, where that something happened that caused these individuals to have a loss of their ADLs, 3 ADLs, where in the previous year they had only impairments of 1 to 2. And so they progressively became more disabled over this period of time. And again, it's these conditions here, the stroke, the congestive heart failure, that rise to the top. And again, this just illustrates that it's just not about the disability, but it's also the mortality that is associated with hypertension as well. And so the greatest risk increases with higher systolic blood pressures and as you get older as well. And so what you have here on the diagram that is on your left-hand side shows stroke mortality. So people who have a stroke and then they die. And so you could see that it increases with not only systolic blood pressure, but it increases with age as well. So the older you are, that increases your risk, and even the higher blood pressure that you have also increases your risk as well. And again, this illustrates the prevalence of isolated systolic hypertension increases as we get older. And so when at the beginning of this talk, I said, as a geriatrician, as someone who cares for older adults, I'm most concerned about systolic blood pressure. This is part of the reason why, is that this shows me that this bar right here, this black diagram here where it's shaded in, talks about systolic blood pressure being over 140. And so you see that as people get older, systolic blood pressure or systolic hypertension is really the one driver of hypertension rather than the diastolic blood pressure. And so this is what I, as a geriatrician, am most concerned about, is the systolic hypertension. We're going to look at some randomized control trials. And so these are some really good randomized control trials that looked at the effects of bringing down people's blood pressures and what those outcomes were. You could see that the mean age for these 5 studies, SHEP, CIS-Euro, CIS-China, and HYVET and SPRINT, which is the newest one that we'll talk about, their average ages range anywhere between 67 to 83. And so the 2 studies that are at the very end, those are the 2 that we'll kind of dive in a little deeper and talk a little bit more about. But you'll notice that not only their age, but their intra-systolic blood pressures are incredibly different as well. Where the SPRINT trial, that new data that just came out last year, their intra-systolic blood pressure was 140 versus these other ones where they were usually in the 170s. And not only that, but the presence of comorbidities in these studies are incredibly different as well. And one of the critiques about these trials is that they leave out really common clinical conditions that live in older adults with hypertension, such as diabetes. People will not only have hypertension, but they'll have diabetes as well. Well, that data, the most recent trial that is commonly talked about, the SPRINT trial, had 0 patients with diabetes. And looking at all the other hypertension trials, it was very, very small as well. And so you'll see that the numbers are quite large, and that's the number of subjects in each study, anywhere between 2,000 to 9,000 patients. And so that's what makes it a very good study, and their median follow-up was a decent amount of time as well, usually about 2 to 4 years. This slide illustrates all of the outcomes. Take-home point from this slide is that controlling blood pressure and reducing blood pressure reduces a lot of the cardiovascular risk. And so you'll see that non-fatal and fatal cardiovascular events, accidents, myocardial infarction, being hospitalized for congestive heart failure, or cardiovascular disease, all types of cardiovascular events, and all-cause mortality. All those things have consistently been shown to have a reduction compared to those people who have been on the placebo. Okay. So HYVET was one of the better studies there. And so I wanted to highlight some of their outcomes and talk about a statistic in medicine that's called the number needed to treat. And for those of you who are not familiar with this, it's the NNT. And what the number needed to treat talks about is that how many people do I need to treat to get that one single outcome, right? And so the number needed to treat for this study that they found that I had to treat 82 people to prevent all-cause mortality. So I had to treat 82 people, for example, here, to prevent someone from dying from any type of cause for over that period of time. And that over period of time was 1.8 years. And so they went over 2 years approximately for patients on this study. They had to treat 60 people to prevent one cardiovascular event, any type of cardiovascular event. They had to treat 241 people to get one person, to save one person from dying from a stroke. And so these numbers put it into terms that it's more easily understandable. And so usually a number needed to treat in the 70s to 80s is actually pretty decent. And so this was considered actually a very positive study. And so that's why, actually, I'm going to go back one slide, or 2 slides here. That's why back in the J&C8 came out, they talked about a systolic blood pressure in people who were 60 and above, of trying to achieve something that was less than 150. So you could see that these trials here, Euro, China, and HYVET, their goal, systolic blood pressure in their trials, was trying to achieve something less than 150. And so back then, that's what the goal blood pressure was. And that's why it was driven like that. And what they also showed, and this just illustrates the exact same thing, that there was a clear separation in terms of people receiving the treatment versus the placebo. And you could see it actually separating already before the one year mark, that there was clearly a benefit to treating people and reducing their blood pressure, trying to get it down to 150. And so the clinical bottom line is that just because of your age, it should not preclude you from being treated for hypertension. Okay. So we're going to talk about the SPRINT trial, and because this made a lot of news, and I think that this has changed clinical practice as well. It talks about, and what it wanted to study, what does a lower systolic blood pressure goal reduce the clinical events compared to a higher systolic blood pressure? And what they defined as lower was that they tried to achieve less than 120, and a higher goal was less than 140. Some of the people that they included within their study is that they had to be less than 50, or they had to be at least 50 years old. They had to have a systolic blood pressure entry of 130 or above. And they had to have one or more of these cardiovascular risks. And we'll go into more detail about this, is they had to have a presence of clinical or subclinical cardiovascular disease other than a stroke. They had to have chronic kidney disease, stage 3. They had to have increased risk of having a event that was greater than 15%, that is based on the Framingham risk score. And also, if you were also at the age of 75 and above, that would qualify you for this study. Okay. These are some of the clinical and the subclinical cardiovascular disease that they wanted to include as well. We're not going to belabor this, but just know that these are people that had actually real disease and real risk of having cardiovascular events. We're going to spend some time on this actually and talk about who they actually excluded from their study. So they excluded people who had previous history of stroke, diabetes, and symptomatic heart failure within the past 6 months. And if you had reduced ejection fraction, so if you had systolic heart failure, you were also excluded. And the reason why this is important is that a common question that I ask within my clinic encounters is, does that study that I reference, or is that study that I just last read, does that apply to my patient here? Does it apply to the person that is sitting in front of me? And so they excluded all these people who had strokes, they excluded people who were diabetics, and they excluded people who had heart failure too. The other big caveat is that they excluded people who had life expectancy less than 3 years. I'm not sure how you can actually come up with that and to determine that. It was a really interesting exclusion, but that was because the study would run for that long, and so they wanted to exclude people who had a life expectancy less than 3 years. They also excluded people who were unable to consent. And speaking from a geriatric standpoint, that's actually a big cohort of my patients that I care for. People with cognitive impairment along that spectrum all the way to dementia. as well. They excluded people who were living in nursing homes, and they excluded people who had a history of poor compliance as well. And so if they weren't taking their medicines, then they didn't want them within their study. And this is something that we'll talk about in a little bit, where we're talking about how great it is to reduce blood pressure, that it is actually very good and it has great outcomes. But we have to do it in the right patient population. And so you have to think of randomized controlled trials as, well, the subjects have to be healthy enough to come in. So they excluded people if their residence was too far from their study clinic site. So people have to be healthy enough to be able to come in for these frequent checks. And so we'll talk about that in a little bit in the second half of this talk. And what they wanted to look at was some primary outcomes, and they looked at composites of people who had myocardial infarctions, acute coronary syndrome, they had a stroke, heart failure, or death from any type of cardiovascular causes, and these are some of their secondary outcomes too, as well. And they found great results with lowering blood pressure down to their goal of 120, but again, they achieved only down to 124. And so this here outlines the difference here, where again, you see that there's a clear separation where the yellow line are people who are intensively treated to get their blood pressure lowered to that goal of 120, and the people who had more lenient blood pressure control and were compared to people with less than 140. And so it resulted in lower rates of fatal and non-fatal major cardiovascular events and death from any cause. And you could also see that the separation between the two treatment groups really started at about the year. At the 1 year mark, you could already see that there was a difference in between the groups, the intensive and the standard treatment therapy. Again, this is some subgroup analysis of their study. What I want to highlight to you is actually the age, because this is a series based upon geriatrics, is that it showed that the benefit of treatment actually favored people who were older adults. And so this is a forest plot, and for those of you who are not familiar with this, the one bar here means that if you land right here, that there is basically no difference, but this actually talks, and if you land to the left of this bar, that means that the intensive treatment or the intervention is better than the standard treatment. And so people who were 75 and above, you could clearly see that there was a better benefit for people who were older. Again, these were people who were relatively healthy to be able to come into their clinic site. And so coming back to the number needed to treat, looking at people over the age of 75 only and above, their number needed to treat was astounding, actually. So the number needed to treat for these people over the 3 years plan was 27. So you had to treat 27 people only to prevent one primary outcome. And one of those primary outcomes was either a myocardial infarction, acute coronary syndrome, a stroke, or heart failure, or death from cardiovascular causes. And so it was actually very significant. And so it's an astounding number. And you had to treat 41 people to prevent one death from any cause. And so that number is also very, very astounding to be able to do that. And so definitely this has changed clinical practice. So the clinical bottom line from SPRINT that we can talk about, targeting a systolic blood pressure of 120 as compared to less than 140 resulted in lower rates of fatal and non-fatal major cardiovascular events and death from any cause. But I want to say that, put this caveat, it needs to be in the appropriate population. It needs to be in the appropriate population. Okay. How about hypertension and the ability to think, your cog function? Well, there's some literature out there too where it talks about, where it shows that dementia incidence is reduced anywhere between 14 to 50% with blood pressure treatment. And these studies, unfortunately, aren't that great because they were never really that was not their secondary outcome that they wanted to measure. And so that's part of the difficulty trying to interpret some Testing. Welcome back, everyone. I was told that you were off and we were just hanging out here in Seattle. And so I'll speed up just to kind of catch up on time, but this forest plot basically is very similar to the previous, where if you cross that boundary of that middle bar, it really doesn't show that there's any benefit. And you see that there's a lot of crossing that happens with all these large studies that they did a secondary analysis at the effects of hypertension on cognitive function. Okay, but the SPRINT trial, actually, the results are still pending, and so they're not published yet, but we will be looking forward to this just because it's a very well done study and looking at its effects on memory over that period of time. And so they are doing some imaging study that is associated with their subjects, and so hopefully we will get some great data from the SPRINT trial and cognitive function. So it's coming. How about quality of life and hypertension control as well? And so many studies have showed that there's a long-term treatment does not really impact the quality of life as well. In fact, what this diagram illustrates here is that the subjective well-being actually correlated in a negative fashion with higher systolic blood pressure. And so what this study did, or excuse me, where this graph derives is from a population who had coronary artery disease, the INVEST trial. And so with these patients, you definitely see that with higher blood pressures, for example, up to the 150s, that the odds of rating themselves as fair or poor increased significantly from here. And so that was consistently shown in a dose response curve. As the systolic blood pressure got better or lower, there was less self-rating of fair and poor in terms of subjective well-being. How about the SPRINT trial and quality of life as well? And so they measured patient-reported outcomes as well, and there was no difference between the two groups of intensive therapy and also the lenient therapy. And so they measured mood using the PHQ-9. They measured different components of physical and mental well-being using the Veterans RAND 12-item health survey. They also measured the patient-reported medications and adherence using a 5-point Likert scale. And so there was no difference in terms of quality of life and patient-reported outcomes as well. And so every single systolic blood pressure reduction definitely counts. And so what this table illustrates, and that we'll transition to the next part of the talk, is that by reducing your systolic blood pressure by 2 points, you're able to reduce your mortality that's associated with stroke by 6, chronic ischemic heart disease by 4, and if you add that all up, by 3 for those things. So every single systolic blood pressure that you're able to reduce counts. So this next part of our talk is now I'm going to present you the data where, well, maybe blood pressure control isn't all that great. And so this first part was saying, well, blood pressure control, the effects are actually a positive, right? And so we're going to come back to the HYVET study too. So this study, I like to highlight this one just because many of their patients were over the age of 80. Their mean age was 83 versus the SPRINT trial, the mean age was 60, or I forget what it was within that slide, but it was nowhere close to 83 though. And their baseline systolic blood pressure is 160. And their medications that they use was a diuretic and an ACE inhibitor that is not available here in the US, but in Europe. Okay, and so this is just to review that it had some significant positive outcomes from controlling blood pressure, that death from stroke, death from any cause, and any heart failure was reduced, and any type of cardiovascular event was also reduced by lowering a person's blood pressure as well. But there's some very important details to this, is that their goal blood pressure was 150 over 80. And less than half of their treatment group actually reached the treatment goal of 150. And so there was a significant portion of people who never reached that goal of getting to their blood pressure of 150 over 80. And again, this is a relatively healthy group of people. because they, again, excluded people with heart failure, dementia, and nursing home residents as well. And so coming back to those important points. With the SPRINT trial, there were adverse effects that were seen as well. Although the overall rate of serious adverse events didn't differ between the two groups, there were things that were seen, differences between the two groups. Those things were hypotension was seen much more frequently in people who were treated more aggressively, of course. Syncope, as defined as losing your consciousness, meaning that they just passed out, was also seen as well. Electrolyte abnormalities was also seen, which oftentimes was related to potassium levels being low. And also acute kidney injury was more often seen in people who were more aggressively treated on their blood pressure. And as a geriatrician, I'm really interested in terms of there was a difference between falls. They did not find any difference in falls, which was also interesting. And they didn't find any difference in gait speed as well, which was also a very pertinent topic that I am interested in as a geriatrician. Now we transition to population-based data, right? And so when you look at population-based data, you get a kind of a different picture versus a randomized controlled trial. So population-based data, you take the entire cohort for everything that it is versus a randomized controlled trial, you're excluding people. So this is just one example, and we'll talk about some other examples where they followed people in Holland. There's two populations that they followed for 11 years, and they took people from the initial age of from 55 to 84, and they took another cohort when they initially had 85, and they followed them for 11 years. They looked at subjects over the age of younger than 65, where their blood pressures were associated with cognitive function. And they also looked at subjects above that age as well. What they found was incredibly fascinating, which we'll talk about in this slide and also in the next slide. Is that they found that people under the age of 65, blood pressure had nothing associated with cognitive function at all. Within 65 to 74, higher baseline blood pressure related to worse function in terms of your cognition. But now when you look at the older age at 75 and above, higher blood pressure had better cognitive function, right? And that effect actually was strongest for people 85 and above. And so people that as you got older, what they saw in population-based data was that higher blood pressures, people had better cognitive function as they got older, right? And so a similar study looked at people at the age of 85 and assessed yearly to up until they're 90. They stratified people over a period of time, low, middle, and high blood pressure. And so they stratified them to those categories of blood pressure. You'll notice that high is 162 to 215. That's pretty darn high, right? And the middle is 147 to 161, which is kind of moderate and acceptable, and that low 110 to 146. And so they found people who were at 85 and they assessed them once a year and up until that they were 90. And so this was a longitudinal population-based study in Holland as well. What they found is at the age of 85 years old, that higher systolic blood pressure was associated with less disability. They also found that there were higher scores on their mini mental status exam. Interesting, right? From age 85 and onward, higher systolic blood pressure was actually associated with less decline in disability and also mini mental scores in terms of a dose response curve. And so that was really interesting. And they actually found very similar things in Europe, in another country, in Sweden, very, very similar things, that they found lowest mortality was seen as a systolic blood pressure that was about 164. And so this is looking at a population data of 50% of people within their country at the age of 85, all people at the age of 90, and all people at the age of 95 and above. And so they looked at low systolic blood pressures and high systolic blood pressures, and they found that the low systolic blood pressures, less than 120, for example, correlated with a higher 4-year mortality compared to higher systolic blood pressure. right? And so they found that the lowest mortality for this population-based data was about 164. So what do we do with this information now? And so this is purely my recommendations, is that think about functional status. Functional status should be the thing that guides our therapeutic goal. And so what I have here is a graph where on the x-axis you have time. So as a person ages, they move along on that x-axis towards the right-hand side. And on the y-axis you have functional status, where you have high levels of functional status at the very top, and then you have low as well. As a person progresses over a period of time, they will lose enough functional status over that period of time as well. What you have here in these dotted lines, the first dotted line here is for assisted living. You could imagine that over a period of time that an individual ages, that they lose functional status where that they have to move into assisted living now. And over another period of time that as they get older, they lose more functional status, and now that they're into a nursing home. And so as a person gets older, there's more impairments and there's more disability that occurs naturally over a period of time. And so with that information, maybe that is what guides us instead of purely based upon age. It shouldn't be purely based upon age. And there are some examples of this in practice guidelines in Europe, for example. So ESH stands for the European Society of Hypertension. And so this is their practice guideline in 2013. And I'm just going to highlight a couple of things here that I'm going to underline in red. So they talk about in fit elderly patients less than 80 years old, systolic values of less than 140 may be considered, whereas in fragile elderly populations, systolic blood pressure should be adapted to the individual, right? And so they talk about how fragile older adults are. And then they also discuss this in individuals older than 80 years with initial systolic blood pressure greater than 160. It's recommended to reduce their systolic blood pressure to between 150 and 140, provided they are in good physical and mental condition. And so it brings into that idea that we should consider what a person's functional status is, their fragility is, and their comorbidity as well. And this is actually incorporated into the American College of Cardiologists Practice Guidelines as well in 2017. So they actually highlight the fact that in the SPRINT trial, they excluded people who were in nursing homes as well. So they specifically talk about in non-institutionalized ambulatory community dwelling adults. And so it talks about people who are able to ambulate and come to the outpatient clinic. And so that's where you could shoot for an average systolic blood pressure of 130 or higher. Okay. And then it also talks about the high burden of comorbidity and limited life expectancy that should be brought into that discussion and consideration for a treatment as well. And this is actually borne out by the data, and this is a very intriguing data that I'm just going to share with you that I think is pretty enlightening. So this is based on the NHANES database, and so it's a very well-known database. But they took people over the age of 65, and they found a cohort, the mean age of 74. They stratified people with high systolic blood pressures, as defined as greater than 140, with normal systolic blood pressure that was below that. And they measured their 6-minute walk. How fast can you walk within 6 minutes? And they determined fast as 0.8 meters per second. 0.8 meters per second is equal to about 33-minute mile. So if you could walk a mile in 30 minutes, that was considered fast, okay? And so what they did is that they looked at the probability of survival over this period of time of 7 years. And I'm going to walk you through this because it's really interesting. So I'm going to group these together. This blue line is the faster walker. Again, if you're able to walk 33 minutes a mile, and that's considered fast, if you were a faster walker, it's highlighted by these two lines that are bracketed here. You had a higher probability of survival if you had normal systolic blood pressure, okay? Which is, talks about how frail a person is. And if you had a slower walk speed that was also found. So this green here that is bracketed now compared to this light turquoise blue here, they also found that as well, is that you had a higher probability of survival if you had a normal systolic blood pressure. But here's where it gets interesting, is now for those people who could not complete the 6-minute walk, the exact opposite was seen, was that now that your probability of survival was actually higher if you had higher systolic blood pressure versus lower systolic blood pressure. And that is bracketed here by these two colored graphs here. And so I think that what this highlights is frailty, and also that higher systolic blood pressures might be better actually in your frail patients. And so taking that into consideration. I'm going to spend a couple of minutes, several minutes talking about blood pressure, and we're going to talk about really mundane things such as how do you measure your blood pressure. And so it's recommended that you should measure your blood pressure taking 3 or greater blood pressure measurements, taken on 2 separate office visits, and seated for 5 minutes or greater. Let me ask you this. I could tell you that I've been into my doctor's office and this has never occurred. I have never waited 5 minutes for my blood pressure. I come from checking in to walking into the office, sitting down, my blood pressure, the cuffs get slapped on and it's a go and it's done, right? And so I ask you, this is basic mundane stuff, and this is actually pretty important stuff where you're trying to take an accurate measurement to base medical decisions on, right? And not only that, but you should be seated actually. And so this is what it highlights, is that you should be seated with your foot securely planted on the ground so it's not hanging off where you're touching, where you're just hanging there. Your arm should be at heart level, which this diagram illustrates, and your blood pressure cuff should be placed very similar to this, right? And so when you are in clinic again and getting your blood pressure taken, think to yourself, did that person just do an accurate blood pressure? Because I bet you they didn't at all, right? This is the SPRINT trial, and this has garnered a lot of attention as well. So what the SPRINT trial did was that they used an automated blood pressure machine. Actually, all the other trials that we had highlighted in this study, they actually use a manual blood pressure cuff. And so they actually use an automated blood pressure machine. They actually had subjects in an unattended room, resting in an unattended room, where 5 minutes of rest was allowed, and there were taken 3 readings, 1 minute apart. So imagine yourself walking into your doctor's office, and the person walks you into the room, lets you sit there for a total of 8 minutes. They put on that blood pressure cuff, it's automated, you sit there for 8 minutes, and it cycles through, taking your readings 1 minute apart after you rested for 5 minutes. Does that ever happen? Of course not. And so I can't really see your expressions, of course, but I assume that that never happens. All right. So one single blood pressure measurement can most definitely misclassify our patients. And that gets back to our previous slide with Mr. MK. We have all these blood pressure measurements that fluctuate so dramatically. Studies have shown that ideally you want to get about 4 to 6 blood pressure measurements to be able to get a good measurement and reading to base some decision making on. And so 4 to 6 is usually what you're trying to achieve. And there's variance in terms of clinic, home, and trying to do it within a research setting as well. But usually about 4 to 6 is what you're trying to get. Okay. Not only that, but it's also recommended that for many older adults that an orthostatic blood pressure should be taken as well. And so you should be able to do it in an accurate manner, but also to do an orthostatic blood pressure. And it should be taken 1 to 3 minutes. And unfortunately, with regular blood pressure, there's errors within that process. But taking orthostatic blood pressures, there's even more error that's associated with that. And so for orthostatic hypotension, it's defined as a drop of systolic blood pressure of greater than 20 or a diastolic drop of 10. And the prevalence increases with age, but it's anywhere between 5 to 30%. So it's about a third of my older patients will have orthostatic hypotension. You just have to check it to be able to find it because it often is there. And so it should be taken in the supine position, blood pressure taken after 5 minutes of rest, like what we had talked. And then you have an individual stand, and after 1 minute of standing, that's when it's the most useful, actually. So you could take it at the 1 minute interval or the 3 minute interval to be able to make it the most useful information. And researchers actually have looked at nurses actually taking this. And so this was in the UK where they assessed nurses where they were trying to take orthostatic blood pressure measurements. The time between positions from sitting to standing ranged anywhere between 0 to 30 minutes, that variable. A third of people, nearly a third of people, immediately after standing, they checked the blood pressure. And so it's not a very accurate measurement. And so oftentimes I ask myself, was this an accurate measurement? And sometimes I check it myself as well. 28%, the arm wasn't supported at heart level when a person was standing, and nearly 50% of people, the cuff wasn't even placed on correctly at that point in time, right? And so it's often not taken correctly, and it's worse than just taking a regular blood pressure. Right? And so this is just returning to our initial case study is Mr. MK, is that it fluctuates so dramatically. And so with these measurements and how much it fluctuates, I often ask to repeat it, or I just do it myself as well. Okay, well, there are certain things that we can ask for, and I'm hoping that CMS, the Centers of Medicaid, will change, is that we can have an ambulatory blood pressure monitoring, is that it's recommended by our colleagues in Europe, but it's this device that this guy is wearing here, and it's basically the size of a phone now, that it's connected to a blood pressure cuff, and it cycles every 15 minutes. It automatically takes a blood pressure, and it records that blood pressure over a 24-hour period. But unfortunately, in our country, it's only indicated and paid for if you have white coat hypertension and no evidence of end organ damage, meaning that you don't have any type of chronic kidney disease, no retinopathy, then it will be paid for. And white coat hypertension is defined as your blood pressure shoots up every time a nurse or a doctor walks near you, right? And this is actually a very common thing that happens. And so getting back to the SPRINT trial, that's why those individuals were left unattended for those 8 minutes. There's no one standing around in that room except for them sitting with that blood pressure machine, okay? So again, our goals of therapy, of trying to start anti-hypertension and driving blood pressure, is that we're trying to maximize function. As a geriatrician, that's what I'm trying to do, is to maximize the functionality for as long as I can. But we do this by trying to minimizing the orthostatic hypotension because that's related to the prevalence of falls as well. And trying to maximize and a person's function is related to reducing the cardiovascular events. So it's a balance that we're trying to do. Lower your blood pressure so that we could lower the risk of having a heart failure exacerbation or having a stroke that can cause a catastrophic disability, but as well as not lowering it so much that it's an impairment in terms of your functionality. And again, trying to maximize quality of life as well. And so what we didn't talk about, that there are non-pharmacologic treatment options. And this is something I think is really important to highlight, is it's basic, it's simple, but we forget it. Is weight reduction, DASH diet, reducing sodium, physical activity, reducing our alcohol consumption has a significant impact upon reducing blood pressure as well. And so you could see that for example, reducing a person's weight can reduce your blood pressure anywhere between 5 to 20 points of millimeters of mercury, right? And so for one single agent at a low dose to treating blood pressure, it usually reduces blood pressure by 7 points. And so all these interventions, if you do it, it is actually equal to one single medicine. And so that's what I want to highlight, and some of the slides that we have coming up talks about that. And so there's a massive amount of influence of weight reduction on blood pressure. It's about, if you lose 1 kilogram of weight, it's about 1 reduction of millimeters of mercury in systolic blood pressure. And so this is one study that highlights that. So larger blood pressure reductions were observed in populations who had an average weight loss of 5 kilograms. So it's about 11 pounds than in populations who have weight loss. So it's about 1 kilogram of weight loss for 1 millimeters of mercury in systolic blood pressure. The effect of aerobic exercise on blood pressure is fascinating and important as well, is that you could see that this is a meta-analysis looking at a collection of different studies, and where that looking at biking, jogging, or a mix of those things, or just simple walking, for example, you're able to reduce your blood pressure by 2.5 points. And the frequency of exercise is also important here. That's over here. If you exercise 120 to 150 minutes per week, you're able to reduce it by 4.5 points of blood pressure there. And so trying to make sure that our clients and the people that we care for also incorporate this in terms of their blood pressure goals and their blood pressure interventions for those who can achieve it as well. Okay. The other thing too is reducing your alcohol too. So people who are able to reduce their alcohol resulted in decreases in their blood pressure by 3 points, for example, and it was a dose-response relationship. The more you were able to reduce, if you were taking high amounts of alcohol, the lower your systolic blood pressure went as well. And so it's a significant contribution as well to blood pressure. The effects of dietary sodium, of course, is also very significant, particularly in the US, is that because the average adult in the US consumes so much sodium. On average, the adult consumes 3.4 grams of sodium in a day, versus when it's recommended it's less than 2.3 grams, so we're well above that. And if you adhere to a DASH diet, it led to lower mean systolic blood pressures. As people without high blood pressure, it lowered it by 7 points. People with blood pressure, it lowered it even more, nearly by 12 points. And so this DASH diet just talks about less red meat, more poultry, grains, fruits, vegetables. Reduction in sodium as well. Okay, and this just highlights that as well, is that it's a dose-response curve. The more that you're able to reduce sodium from your diet, the greater the impact that it has on blood pressure reduction. And so you see that the sodium level here is on the x-axis, where it's measured as high, intermediate, and low. And the lower that you're able to go in terms of a sodium diet, it actually reduces your systolic blood pressure more, of course. So finishing up, some recommendations. Your treatment decisions, particularly for me, it's really based upon functionality. Is how functional is that person in front of me? That's what I'm basing my treatment decisions on. Most older patients will require usually about 2 to 3 medications to meet their goal. We didn't talk too much about this, but usually a diuretic is usually part of the regimen plan, just because older adults are incredibly salt sensitive. And also that there's a decrease in cardiovascular risk that's likely related to decrease in blood pressure, rather than any type of medication. And so there's great literature about different classes of medications to treating blood pressure. There's controversy about that, and it's related to which agents are better, but most people think that it's a reduction of blood pressure really that does it, rather than specific types of agents, unless you have some sort of comorbid disease that requires a specific agent. And so what I would say is, coming back to this diagram, is perhaps thinking about functionality. And maybe the greatest impact that our blood pressure treatment may have is when people have the highest functional status, when they're well enough to come into a randomized controlled trials center, get their blood pressure, get their test done, and they're ambulating. And so there's very, very little disability that they have. But as a person ages, or as their disability mounts, there maybe then at that point, it has the least impact at that point. Okay? So there are many areas of uncertainty still. How best to define old? how best to make the diagnosis. As you all know, that when you go to your doctor's office or your provider's office, that they're probably not getting a very accurate blood pressure measurement. And so how do you make your decisions based upon that? And what should our treatment goals be based upon? Is it age or is it functionality? My opinion is that it should be based upon function. So conclusion, systolic hypertension is very common in older adults. Age by itself should not preclude any type of treatment. And aggressive treatment of systolic hypertension in frail older adults with many comorbidities may be very harmful. Okay, so I'm going to end there and take questions.
Don't have any yet. Do we have any in the room? Someone's typing.
Oh, okay.
Maybe, can you mention a little bit about some of the like home blood pressure monitors that people sometimes are using, like on their wrists and that sort of thing?
Yeah, so, well, I think they heard your question.
Yeah, they heard mine.
Okay, good, good. And I was just making sure whether they heard your question, Barb. So those monitors are actually pretty accurate now, and but the newer models are pretty accurate. And so I do take that into consideration. There's a body of literature out there, particularly related to outpatient home monitoring of blood pressure and how to interpret that data. And so oftentimes it's not so much the device, but it's how it's taken. And so all those things that we talked about here, positioning, making sure that you are seated appropriately, your arm and the cuff is applied appropriately, and that you've waited for 5 minutes, then taking your blood pressure. That's actually the more significant thing rather than the device itself. So when I am trying to make treatment decisions based upon a home device, I will ask my family members and patients to bring in their machines so that we could calibrate it just to see how off we are based upon that data. And so I hope that answers your question.
So are there any studies linking, interesting question, constipation to higher blood pressures in older adults?
I can't say that I know of any. But what you're probably getting at is that many older adults would be on a diuretic, and so taking a diuretic depletes that as well, depletes your volume, and so it can cause people to be constipated in that sense, but I can't say that I have looked at specific studies looking at constipation and hypertension. There are side effects of medicines. Calcium channel blockers are notorious for causing constipation used at higher doses, and so that's also observed. But I can't say that if there was specifically a study looking at hypertension and constipation in itself.
And what about taking the blood pressure of a bedbound patient in terms of positioning?
Yeah, and so if a person is bedbound, then I would take it in their natural position, meaning that if they are completely bedbound and they're not up to a seated position in the wheelchair, then I would take it in that position and making sure that the cuff is placed appropriately and it's still at the heart level, for example. And so I still will take blood pressure based upon that. But if a person is in a seated position, such as a wheelchair, but they're not able to stand up, then I'm also doing that within a seated position, making sure that the arm is supported in that position.
So just to clarify, is it best to take orthostatic blood pressure at 1 minute or within the first minute of changing positions?
Yes, at 1 minute, at either 1 minute or at the third minute. Yeah, but one minute is usually what most people would do just because it's more efficient. So you're not waiting an additional 2 minutes before you take it.
And is there an optimal time of day to take blood pressure?
Yeah, no, there's not an optimal time of day. And so that's why when we talked about the ambulatory blood pressuring machine where it cycles every 15 minutes, your blood pressure will dramatically fluctuate with what you're doing, what you're thinking, what you're eating. And so there's not an optimal time of day. I want it to be consistent. And so if I'm going to base my decisions on something, I ask individuals to take it consistently always at that time. So don't give me a blood pressure that at 5 p.m., then the next blood pressure getting it at 6 in the morning. Just give me the same blood pressure at the same time and more consistent.
And you segued nicely into the next question, which is, would you make a treatment change based on a blood pressure taken with a wrist cuff?
Yeah, I would too. And so it's just making sure that it's calibrated and it's taken and placed in the right position.
What are your thoughts when the person has a difference between both arms? One is 10 or more millimeters of mercury.
Yeah, and so usually you would take the higher blood pressure arm, and so that's what most clinicians should be doing, is that they take the arm with the higher blood pressure. Usually that indicates that there's some sort of vascular disease present. So.
And how accurate would a blood pressure be if taken with a cuff over clothes, which you see a lot in the clinical setting now?
Yeah, and so the clinical teaching is that it should not be over clothes and that it should be to skin. And so studies have looked at the differences, and so it is variable. And so I can't, off the top of my head, tell you the impact or how lower or higher a blood pressure is based upon clothing, because then you have to talk about, well, are you talking about clothing in Seattle, or are you talking about clothing in Southern California where it might be a long sleeve shirt versus in Seattle where it's over a coat? So.
Okay. What do you think about taking blood pressure on the lower arm because of obesity? For example, the cuff is too small for the upper arm.
Yeah. And so that talks about cuff size, and so making sure that you have an appropriate cuff size is very important. And so it should be in the upper arm if at all possible, rather than within the lower arm.
For a patient on triple antihypertensives, any value in taking at one time in the morning, one at noon, or one at night, or all three of them in the morning for adherence?
Well, I think if your question is about adherence, then taking it all at once definitely increases your adherence. And it really depends on the circumstances of why you want to separate those blood pressure medications out. But if it's related to adherence, then you definitely would try to group them all together to increase adherence. So hopefully that answers that question.
So I don't have any other questions. Any questions occur to you?
One more question. People who live in a stressful life, they can impact in that high blood pressure?
Excuse me again?
The people who live in a stressful life can impact in that high blood pressure?
So let me understand. For the audience, so there was a question here in Seattle. People who live in stressful lives, do they have high blood pressure? Yes. And so people who have more stressful lives have definitely have higher blood pressures. Yes, correct.
I recently heard a nephrologist mention that BP control can be improved with nighttime dosing. Exception is diuretics. Have you seen any studies supporting this?
Yes, there's some studies particularly related to ACE inhibitors or ARBs as well that shows that potentially that taking them at night is helpful. But for many of my patients, it's usually about compliance, and so remembering to take it is an issue. And so I don't usually separate out the medicines unless there's a reason to. And so oftentimes I'm just struggling to make sure that medicines are being taken. But yes, there's some limited research that shows that.
And then What are your thoughts on giving losartan? Is that pronounced right? Twice a day. I'm seeing it given BID recently.
Yeah, and usually when losartan is dosed twice a day, it's usually a nephrologist that is doing that, and it's related to the renal protective effects. And so I don't know your specific clinical condition that would be split in. But again, like I was saying, it's usually about compliance that I'm usually concerned about. But medicines like lisinopril, which is an ACE inhibitor, or ARBs, have been dosed as twice a day as well. So there's a lot of variability in terms of clinical practice, such as a lot of variability as taking a blood pressure. Even.
Yeah. So someone else is typing, otherwise I don't have other questions. We'll see. Well, I think that must be, oh, here. What if a patient has a blood pressure change from one arm to the next? What if we see amount of 20 difference in each arm? Would there be a reason for that?
Yeah, and so if you have a very significant difference, and 20 would be significant in one arm versus the other, that's an indication that there could be vascular disease in one of the arms. And so you would have to think of how your blood pressure and how blood flows, that there could be more plaque buildup that's associated on that side of the arm that has a higher blood pressure compared to the other side that has a lower blood pressure. And so your aorta comes off in a way that the blood flows to the left and to the right, not in a symmetrical fashion.
Okay, I think that's it. Thank you.
Yep, thanks.